Well, welcome everybody to Optometric Education Consultants National Webinar Series, Sunday night edition. Our topic tonight is tiny eyes and bigger challenges, managing pediatric ocular disease, with Dr. Nidhi Rana. She got her optometry degree and her master's degree in clinical optometry at Pacific University's College of Optometry and completed her pediatric residency from Illinois College of Optometry. She's a fellow of the American Academy of Optometry and currently works in a private MD/OD pediatric specialty practice in New Jersey, as well as at the prestigious Will Eye Hospital Pediatric Ophthalmology Department in Philadelphia. Her specialties include treatment and management of amblyopia strabismus in pediatrics, specialty contact lenses, including aphakic fittings and genetic conditions in pediatrics, and lectures both nationally and internationally. Greg and I have had the opportunity to work with her at other conferences for several years, and we're just so impressed in her facility with the information, her ability to really communicate what she does, and it just belies a clear understanding of this topic that few actually have. So with that, Nidhi, please take it away.
Thank you so much for that kind introduction. And just like you said, yes, we've known each other for a while. And I'm truly honored to be here. I know they mentioned about the survey, and I would truly appreciate you taking your time to submit that survey. I love to lecture, and I was just telling them earlier how I enjoy doing this. And I actually look at your feedback very carefully and also like to improve myself. So even though I've been doing this for a while, I still want to improve myself. So if you ever have any, give me any kind of advice, please do so. So without any further ado, let's get started. I have no financial disclosures to make. This is my email, drnidhirana@yahoo.com. That's my phone number. If there is ever any question I can answer or help with any pediatric case, or just call to say hello, feel free to do so. These are my three kiddos, and Greg and Joe have seen them grow up pretty much because they used to be much younger than they are now. Oldest is 18, she's off to college. Middle one is 15, he's in 10th grade, and the baby is, who used to be little now, is going to be 12. So they're all growing up. Coming to what I like, when I see kids from 0 to 18. 0 to 3 is my favorite. 3 to 6, 7 is I like. 8 to 12 is what I will do. And after that, I'm like pushing myself to see them. So just like Greg was saying earlier, that is not my forte. After 18, see ya. So, Greg, could we just poll for this first question so I get an idea of how many of them see pediatrics?
Absolutely. The poll question is open. If you want to read the question to them, Nidhi, that'd be great.
Sure, of course. What age group of pediatric patients do you most commonly see? Infants, 0 to 1-year-old, toddlers or preschool kids, 1 to 5 years old, school-age children, more from 6 to 12 years old, adolescents, 13 to 18 years old, which is not my favorite. And then I do not see any peds patients at all.
Joe, I'm suspecting there's probably no questions at this point.
That is correct.
They were rolling in nicely here, Nidhi. Again, you will not see it. I can see them on my end.
Great.
And it looks like things have slowed down nicely. So it looks like the percentages are in. So here's what we have for tonight. We have no one going 0 to 1. We have 7% going toddlers to preschool. We have the majority, 54% going 6 to 12, then 36 going 13 to 18, and 2% saying they do not see pediatric patients.
Well, great, because some of these cases that I've picked are in the younger age, are in the kids that you are not seeing. So hopefully you'll get clinical pearl here and there out of it. All right, so can I continue going on then?
Yes, you
Absolutely.
can.
All right, perfect. Okay, so let's start off with this 3-month-old baby who was referred. Before I get started, a crux of where I see patients comes from our pediatricians. So if you want to get into pediatrics and see the younger ones, get a good rapport with your pediatrician. These parents, even including ourselves, we really rely on our pediatricians to give us guidance, who to see, who not to see. So if you have a good rapport with your pediatrician, they tend to guide their patients to see you. So I think that is the majority of where we see our patients. So I'm at Will's and I'm at a private practice, which is an MDOD practice. We only see kids. And normally we get referrals from 250 pediatricians in the area. So if a pediatrician calls us and says, you're going to see this patient, or can I send them to you? We're like, oh, yes, we're going to see them, because we again rely on them for referral. So we're not going to say no to our pediatricians. So this little one comes in, 3-month-old baby for an enlarging lower lid mass since birth. It has a purple discoloration to it per mom, no tenderness. The kid's really doing okay with it. She denies any trauma. She's a full-term born otherwise, no developmental delays, normal delivery. So you're asking all your normal questions that you would do when you see kids. No medication she takes for anything. When you look at the picture, you can definitely see, and Greg told me this, that I can just move my cursor here and we should be good. The kid fixates and follows with each eye, so we know the kid's seeing a grossly normal posture, so you're not seeing an evident strabismus. Again, the baby's only 3 months old. You're not really looking for your typical strabismus because she's only 3 months old. When you're describing what you're seeing, it's very important whether you send that information to a pediatric ophthalmologist or you're returning a letter to the pediatrician giving all your assessment and plan. It's very crucial to kind of give yourself and write down the details of what you're noticing. So here I notice is this kiddo has like an S-shaped lesion, which when I push on it feels very squishy, like I would call it bag of worms. You can see a small capillary kind of head to it. So again, these details should give you some idea. It's causing this ptosis, inferior ptosis. So again, I always say on my watch, none of my babies, when I say babies, I mean my patients, will hopefully ever get amblyopia, because I'm gonna keep watching that. That first decade of life is where these kids can end up with visual deprivation for some reason or the other. And hopefully those of us who are seeing pediatrics remember that amblyopia is something we don't want them to have. So once I've said this, I'm not noticing any proptosis on the eye. This is a palpable mass, again, like a squishy bag of worms. So we do retinoscopy, and usually we do cycloplegic retinoscopy in younger children. That's up for debate for some who think just tropic and fennel is okay. Some of us who do cyclo for the little kids, and I usually tend to do the cyclotropic on my younger children. So you can see a significant difference in astigmatism. So remember, any mass that sits on the eye, when it pushes against the globe, it can kind of change the shape of the eye a little bit, and that changing of the shape can induce astigmatism. Amblyogenic when it's anisometropic like this, so more the reason why we should be having the red flags to treat this aggressively. Rest of the eye, anterior and posterior segment look normal. So what am I thinking as far as differential diagnoses? In that younger age group, you're thinking of dermoid cyst. If you look at this picture right here, right superior temporal right here, this kid has a little bit of a lesion right there. If I pushed on that lesion, it would be more tighter, it would be more fuller, and it would look like it's almost adhered to the bone. It wouldn't be like the squishy kind of mass that I'm seeing. Dermoid cyst also tends to change over time. So kind of that's why I brought it up, because it's the same way that this other lesion is also changing. So we're thinking in those terms that could this be a dermoid cyst that happens to be from birth, but then will also change over time. Normally, dermoid cysts should be surgically removed. I just had a patient not too long ago, maybe a few months ago, who came in with actually an orbital cellulitis, and when we traced back, they never got the dermoid cyst removed, and the dermoid cyst like actually burst, like your appendix just burst, caused tons of inflammation, caused the orbital cellulitis, and had a whole messy situation going on there. So normally, if you see dermoid cysts, we send them to the oculoplastics or your pediatric ophthalmologist if they're comfortable with removing them. At Wills, we usually only send them to oculoplastics because we have a department. Is this trauma-induced swelling? Of course, to keep that in mind. A younger child who's not mobile really at this age, 3-month-old baby, not doing it themselves. But when we see kids, you have to keep in mind child abuse on the back of your mind, because it is amazing. Those of us who see pediatrics do get that child abuse case here and there, and that's why you have to be aware of it. Mom denies trauma. Keep that child abuse in the back of your mind, but for right now, she denies trauma, so not swelling with it. Could it be a cellulitis? Of course it could. You can see a cellulitis looks more red. Kid is more irritated. If it's orbital cellulitis, kid's not like this happy kid who is just goo goo gagging over there. The kid's really miserable, may have a fever, not feeling as great. And those kind of cases has to go to the hospital to get admitted for IV antibiotics. Achillesian is again very common in children as it is in adults as well, where you do have this little localized swelling that you can see right near the lid lash. Could be really a beginning of a chilasian, could be more hardened chilasian that's sitting there, could be a hordeolum. And in this case, it didn't really fit that idea of a chilasian. So what else could it be? That's like a capillary hemangioma. That little capillary head gave way when you touch it. That squishy bag of worms kind of gave way. So those are the things that kind of tell you that the assessment here is more a capillary hemangioma. So what am I thinking? It's a capillary hemangioma of the left lower lid. It's causing induced astigmatism. Anything greater than 1.5 diopters of astigmatism between the eyes is amblyogenic. Again, these babies on my watch ain't going to get amblyopia if I can control it. It's treatable. So why wouldn't we do what we have to fix the problem? So being at Wills, we do have a hematology, oncology, hemangioma specialty group at CHOP, so Children's Hospital in Philadelphia. So we usually send our kiddos to see them. They do extra testing. They'll do the workup. They'll do the treatment, but we just ship them off to CHOP to get further workup done. This is exactly what we did this for this kiddo. So what is a capillary hemangioma? Kind of just the name gives away. It's a benign hamartomas of capillary endothelial cells. It's very common vascular tumor of childhood in the orbit. You can see them as preseptal, so more superficially, just like we see preseptal cellulitis, so it's more superficial in the orbit. You can see them more intraorbital, so more deep-seated in the orbit, or they can come as a compound or mixed, where you can have them both in the front of the eye and as well deep in the orbit. Sometimes the hemangioma group will actually do an MRI as well to see how deep the capillary hemangioma goes into the orbit, in case they want to do a procedure or something else to fix it. Females and premature kids are more prone to this. They do have a rapid phase of growth, just like mom said. From birth, it was fine, but then it's been increasing in how big it's getting. And that happens usually in that first 6 to 12 months of life. Then they have a slow involutional phase, which can even continue through the first decade of life. So they can still continue grow. What are my risks? And we touched on this, but we're going to go over it because that's important to keep in our mind. Deprivation amblyopia. In this particular kid, you can see how much ptosis it's causing, and it's covering the visual axis. So we know that the kid ain't seeing much, and that's going to cause deprivation amblyopia. This is again a giveaway. If I just looked at this picture and someone asked me my opinion and said, what do you think that lesion there is? It looks like a capillary hemangioma. Look at all the things that give way. The color, it looks like a little purplish color with the veins and the capillaries, right? You're getting that little purple discoloration hue. There's a little small kind of capillary heads to it that also gives away that this is a capillary hemangioma. And if this baby was somebody you were seeing, you would just kind of palpate and see, you would see it more like a squishy bag of worms, and that gives away too. Again, you're looking for proptosis, especially with the deep orbital ones. They sometimes can change and deform the globe, and they can cause that proptosis with it. We talked about refractive amblyopia. If we have unilateral astigmatism, one eye more than the other, it can cause a risk for being amblyogenic and hence cause amblyopia. So again, on our call, our baby should not have that, because that is something we can definitely manage. Let's think about treatment. So this first page of treatment is really what was traditionally done when the kids were having capillary hemangiomas, and then we'll go to the treatments of what they typically do now. So for very small lesions, we're just going to observe it. Who cares? It's there. It's not bothering the kid in any way. You do nothing. You watch it and call it a day. Surgery was done for these, and I happened to be on one of the surgery for capillary hemangioma. Don't ask me why I thought that was a good idea. I was like, yes, I have the opportunity to go. I will go see it. Not smart idea. There was blood everywhere. It makes sense. It's a capillary vascular tumor. It's going to have blood everywhere. Not that it bothered me, but I was just thinking I could have found something else to see if I really wanted to. But that's smart thinking 20 years ago when I was much younger. Intralesional steroids, ophthalmologists were giving intralesional steroids or ophthalmologists and even, hemangioma specialists were giving steroids into the lesion. And the idea was to give these steroids slowly, so inject it slowly, molecule per molecule. When they gave a quick injection, all the molecules could cause like a rush into the eye and a central retinal artery occlusion. So a skilled surgeon was really important to give the intralesional steroids. Then they moved on from there and they started doing systemic steroids. And we all know, kid, adult, it doesn't matter. Systemic steroids do cause retarded growth. They can cause elevated blood sugar levels. They cause resistance, reduce resistance to infection, and many more side effects that come with it. So obviously, things that moved on from there. So accidentally, they came across using oral propranolol for capillary hemangiomas. Think of it. Propranolol has been used for all of you who see the older patients for their cardiovascular diseases, for hypertension. It's a beta blocker, and it's very commonly used. But when people were on it, they realized accidentally that it actually shrinks the capillary hemangiomas. So oral propranolol is given, dosage starts at 1 milligram per kilogram per day, divided into twice a day, and then increased to 2 milligrams per kilogram per day as the kid tolerates the medication. 40 to 50% of them within the first few months will show a drastic difference. You can see this kid over here. Look, we have this lid that's kind of droopy and so much of ptosis, and all of a sudden you can see this eye beautifully showing very minimal ptosis, if at all, and the great visual axis. So we know that the amblyogenic part of it is at much less risk at this point. From the propranolol, you can have side effects. It's a beta blocker. It can affect and cause fatigue, hypotension, hypoglycemia. So many of these kids are admitted in the hospital when the hemangioma group or the hematology, whoever is doing their care, gives them the medication. They'll stay there for a day or two. And once they look like they're able to tolerate the medication, they're sent home with oral propranolol, and then they do the course for many months. Topical beta blocker at some point was also used for small lesions. If I see a kid with a small lesion, I tend to use it too. It's timolol gel twice a day, and see if that helps. Very small lesions, it will help. If it's a big lesion, like in this kid that you're seeing here, it doesn't tend to help. You have to go and see the hemangioma or the oncology, hematology group, whoever is managing these kids in and around your area. And this is our patient. If you can see on a 2-month follow-up, you can see that S-shaped ptosis is beautifully like gone almost. You can see that you can barely see that ptosis anymore. She barely had anything. She did this course for about, I want to say, 6 to 8 months. Many of them do it for about 8 to 10 months, even to a year, and then many of them actually stop using the propranolol. So oral propranolol for capillary hemangioma. So that's our first case, 3-month-old baby, super cute. Like I said, 0 to 3 are my favorite. And anybody I see in that age group, I really enjoy seeing them. I can do my gaga. Sorry, go ahead.
No, I thought you were done there. I have a
Yeah.
question for you when you're done with that thought.
Yes, of course. No, I was just saying I love seeing that age group.
The question I had, you brought up about child abuse. In Pennsylvania, we have to take child abuse course. And then I'm hoping the answer is no, but I'm going to guess with what you see. Have you had to ever report anyone for the child abuse?
Yes, it was not only me because I was involved in the care at the time. There was an ER patient who our pediatric ophthalmologist actually saw in the ER, and then they had sent the kid upstairs to the pediatric floor to have some parts of their eyes checked. And when she sent them over, I happened to be part of that care. And the kid, I happened to just ask what happened. And I'm sure they asked that in the ER in Wills also. But the kid, I don't know at that time said something or not. But when I asked him, he said his mom hit him with a belt. So that caused the laceration. So yes, we had to report it, unfortunately.
Do you have any tips on how easy it is to report or how to report? I guess would be the
Well, it's always hard to report, as you know, but we usually have a social worker at the hospital, so you don't want to get involved in it. You just kind of want to walk out and tell the social worker that this is what you're noticing. You finish your exam and walk out of there. Or if you want to bring someone in, like a security or whatever, if you feel uncomfortable in the process, because parents sometimes get agitated if they're listening that there's a social worker coming in or whatever. But many times, then the social worker sends the info to the child abuse team, and then it's all behind the scenes, which I don't have any clue what happens from there.
that's the point I want to point out. So anyone ever suspects, please just call. It's all anonymous. Whether it's false or true. They're going to weed that out. So if you ever suspect it, just please report it. So okay, that's it.
Yeah,
Here's
it's always for the
here's
kids' benefit.
here's a quick question that just came in. Do you encounter symptoms consistent with dry eye disease, or is this people who are using electronics and screens? What about your pediatric
Oh,
population?
we're talking about a random question. I was thinking it was
Yeah,
associated with
no.
dry eye and electronics. Yeah, all the time. You see
In
kids
kids?
coming in
Okay.
all the time with dry eyes. I have to say that diagnosing dry eyes in kids is very difficult. As you would know, you're not doing a Schirmer's test. You're kind of really looking at the quality of the tear film under the slit lamp. If you can put the fluorescent dye and look at the tear breakup time, that's my way of telling. But symptoms are more what it is, rubbing the eyes, blinking a ton. Those are kind of my thought processes. And if the parents say they've been on electronics like 6, 8 hours a day, that kind of also rings a bell. So yes, we do see that many times.
Very good.
All right. So moving on to our 5-year-old. Again, pediatrician's office, they failed an eye exam. They came here to rule out amblyopia. They've never had an eye exam before, no meds that she's on. Healthy kid, birth history is unremarkable, and family history is unremarkable. So if you're looking at this data over here, it looks like a normal myope that comes in without any prescription. She sees 20/30 in one eye, 20/40 in the other. Pupils are normal. UMs look good. Retinoscopy looks mild myopic. Great. She sees 20/20, and we call it a day. So very common myope that would come in your practice to see. Anterior segment, unremarkable. Posterior segment is, I'm going to show you a picture. A hypopigmented lesion that I see, well-defined margins. So again, you're describing everything you see because that's only what we should be doing. So this lesion is right above the macular area. It just looks like a little punched out excavation. It's not causing any vision issues for this little kiddo. So we know that it's not having any problems visually. So what are our differentials in our mind that we should be having an eye on? So let me show us some pictures before we go on. So congenital hypertrophy of the RPE, the Sherpy looks more, of course, like a bigger punched out area that we can see. This kind of does not really look like it, so not on my radar. You have a retinal coloboma, and you can really see a large excavation kind of area that you see with the colobomas. They're many times associated with iris colobomas as well. So again, comes with many of those things too to keep in mind. Amelanocytic nevus, sure, could be. But in our case, it's a torpedo maculopathy. So it's right near the macula, solitary thing that you find and does not affect vision. So just like I mentioned, it's a solitary congenital nevus of the RPE. It's oval shaped many times, variably pigmented. It's temporal to the macula. In my case, it was just atypical. It was more superior, but somewhere there. And many of them will have like a trail to them. And I'll show you some pictures where it kind of really looks like a torpedo, and hence the name. There are two types of it, type 1 and type 2, and that's based on the OCT findings. Etiology, this kid was 5, wouldn't sit for an OCT, so forget that, but I will show you some OCT pictures of them. The etiology is, the thought process is there is some alterations in the choroidal vasculature in the macular area during that embryonic development that kind of causes this kind of a maculopathy. Dr. Shields had presented this case back in 2010. It's a while ago, and there have been many other torpedo cases that have been reported since then. But the pictures were very good, so I just wanted to show you. You can see that little trail I'm talking about. You can see them being more oval, temporal to the macula. Two pictures, variably pigmented, but kind of give you the same idea that it is looks like a torpedo, and that's why it's called a torpedo maculopathy. It's mostly a coincidental finding. You just look at the retina if they've never seen an eye doctor before and you find it. They have no visual loss with it, but they could have a scotoma depending on how big it is. So this is a picture of some that I got off the internet to just show you some pictures of the OCT. The type 1 usually has the retinal attenuation, outer retinal attenuation, without the retinal or the choroidal excavation. And the type 2 will have it with the retinal and or the choroidal excavation. Now, what I didn't add to this, if I was going to complete this case, would tell the parents she's myopic. We would have a long talk, of course, about the torpedo maculopathy. We're going to watch it. It shouldn't change. This is just a coincidental finding. Here we got some pictures, and we're just going to follow it. But what I would have added to this, which I didn't put it here because we're talking about ocular disease, is myopia control, because that's, again, what we do in pediatric cases. We would talk about the different kinds. Now, that's a whole lecture that I do as well. So we're just going to touch base on it, but that's what I would have talked about with the parents as well, just to kind of complete this case for this kiddo. All right, so moving on. Now, I see how like the age group is getting older and older, and it's getting to a point where I'm getting like uncomfortable wanting to see them. They just slouch, they just sit, I have 2 teenagers, so you can imagine that it's not my forte, even though I do see them till they're 18. So this is a 13-year-old. I've seen her forever. She's a high myope, and seen her since she was a little kid. So that morning, she calls the office and says, my one eye is dilated and I want to come in. I happen to be in clinic, so obviously we see her that day. She was putting her contact lenses in and noticed that the right eye was dilated. She's currently on no medications. Now that she's 13, we're really not doing much about the myopia control. She has been stable for a while, but when she was younger, we did have a history of doing the low dose atropine eye drops for the myopia control. Back in the day when she was doing this, there was no MySight glasses. She wasn't interested in doing ortho K, and we didn't have the Stellitz lenses, so she was only doing the atropine eye drops. When anybody comes in with they call a dilated pupil, it's your and my job to make sure you don't go with what they're saying. You do your workup to make sure, is the larger pupil the problem or is the smaller pupil the problem? She doesn't know. That's your and my job. That's why we went through all this training to fix that problem. Just because she's saying the right eye is dilated, that might not be the case. The other eye might be the problem. So let's see what's going on here. She's wearing her contact lenses. She sees 20/20 -2 in each eye, perfect vision. That pupil is dilated on that side. The left eye was normal, but no APD. Confrontation visual fields and color vision was normal. She had no strabismus, anterior seg, posterior segment was all unremarkable. So high myope, like I said, a right eye greater than the left eye, but stable, nothing has changed. And so far, everything is looking where it should be, except that dilated pupil. So what am I thinking? Horner syndrome? Sure. So when I'm looking at a Horner syndrome, I'm looking for a few things that kind of triggers me to get that child evaluated for Horners. Now, you can have Horners that is congenital. So some kids, while they have birth, they have a traumatic birth. Back in the day when we used to deliver children by forceps, they had more a risk for having traumatic birth because of it, as they're pulling the child from the vaginal canal, and that could cause a Horner syndrome. Sometimes their neck muscles get stuck while getting them out of the birth canal, and that also caused a Horner syndrome because of trauma. That's congenital Horner syndrome. You would see it since the baby is little, no changes. Now, this is an acute onset. Of course, that goes out of the door. So what else can I think? Is this acquired Horner syndrome because it's a new onset? Now, if I'm looking at this picture of a Horner syndrome, one, I have to look at the irides. In this kid, the irides are both the same color. Some of the Horner syndrome patients will have heterochromia, so different color irises. The pupils, of course, are anisochoric, so we see the difference between the eyes. If you look very carefully at the ptosis, you're going to see a ptosis on the top. Look at that difference. It's subtle, but it's there. What you also have to remember with Horner syndrome is you're going to get inverse ptosis. Look at this lower lid also. It's a little higher than this lid, which is again prompting me that this is probably a Horner's syndrome in this particular child. The other thing to look for is how much difference do you see of anisocoria and bright light and dim light, and it should be worse, more in the dim light. So that's Horner's. She doesn't follow any of that, so that was not on my radar. Could it be a third nerve palsy? Of course, could be anything neurological. Think of it. And it's our job to kind of wean us out through this. She has no ptosis that may come with a third nerve palsy. Her eye has no EOM issues, so elevation's good, depression's good, adduction is good. So could she have a partial third nerve? Yeah, but just didn't fit of what she was trying to tell me. So right now, that was not on my radar, to be honest. Could it be an 80s pupil? In younger children, it's not as common, don't really see it. But the pupil will not constrict well to light, but it will do for near, and hers was like a fixed pupil. So that, again, did not follow the 80s pupil. Could it be trauma induced? She denies any trauma, so I'm going to take her word for it. But what else am I looking for when I'm looking at her pupil? Could I see any signs of the pupil itself or the iris having any problems because of trauma? Then we would know, could there be a foreign body? Could she have a surgery before? None of that kind of gelled together. So again, as much as she said no, I'm thinking no trauma. Could it be physiological anisocoria? Stress can do anything in our lives. Stress, you can have this, you can have that, you can one day wake up and have physiological anisocoria because of stress. Yes, it happens. But in this case, again, we did not see that equal anisocoria and dim light and bright light. So again, it was something that was still on my mind, but not perfect. So none of this is falling into it. So if you take away from any of these cases, please take away to think outside the box. That's what our brain should think of anytime we're seeing any patient outside. Kids, adults, doesn't matter. So what am I thinking? Okay, this is a new onset dilated pupil. I'm thinking now this is the problem, the dilation. Should I get an MRI done, which makes sense, obviously, but before I put the kid under to get an MRI, she's 13, she may be able to do it awake, but I'm still contemplating this. I'm asking her again everything that I can think of before I send her off to get an MRI done. Child, and I've learned over the years, I've been practicing for more than 20 years, and I've learned over the years to ask clear questions. Are you taking any medications that maybe your pet is using, like phenylephrine, tropicamide? I don't know, for whatever reason, you help your pet with it, now you touch your own eye. Were you at an eye doctor's or somewhere else where there was an eye drop that you touched accidentally and put it in your eye? Are you eating any kind of supplements? Are you taking any specific medications? No, no, no. And then she says to me when I asked her, do you use any kind of wipes? Yes, Dr. Rana, I use Qbrexza wipes. Well, duh. So Qbrexza wipes, let's talk about it. So the plan is to stop Qbrexza. Let's not go to get an MRI done. Qbrexza wipes are glycopyrronium. They are used for excessive sweating underarms and for hyperhidrosis. So a lot of children with anxiety, even adults with anxiety or with other conditions that causes a lot of excessive sweating, dermatologists tend to prescribe Qbrexza wipes. They're easy wipes. You use it underarms, on your hands. You're instructed to wash your hands, but many of them don't do it, and then they can cause a dilated bilateral pupils or unilateral pupil in this case. It contains glycopyrronium tosylate, which is an anticholinergic medication. So let's go back to our pharmacology. Acetylcholine in the body or in the it helps our eye or a pupil to constrict via the sphincter pupillae muscle. When you use this wipe accidentally in your eye, you're going to block the muscarinic acetylcholine receptors that will dilate your eye, and hence why she had a dilated eye. So, and then, of course, it blocks accommodation and so on and so forth. But we stopped the Qbrexza. I saw her the next day because now I'm thinking if this doesn't work, she's getting an MRI because you want to keep that in the back of your mind too. Don't let them go. Do not let kiddos go. Make sure you're on top of it. Many people have my phone number. It's good and bad in its own way. They'll call me for insurance purposes too, and I'm like, I do nothing about that. But when they really need me, I want to make sure they have it. So we kept touch base. The dilation went away. I did see her back in the office. She was doing really good, and we called it a day. So no Qbrexza wipes for this young lady. All right, I'm ready for our poll too, Greg. I'm sorry, I was going to say the question. When a child comes in for an eye exam, so you're seeing your patient, do you also turn around and check the eyes of the sibling, whether they come in with one sibling or two siblings who are present? I don't mean you're doing a full workup. I'm just saying, do you turn around, look at them, take your retinoscope, quickly look at their eyes, or maybe your direct ophthalmoscope, quickly look at it, take that 2 seconds, is what I'm asking. So yes, I do that routinely. Sometimes I do it, rarely do it, or I never do it.
Okay. The polls are being answered as we speak.
Wonderful.
Joe, are there any other questions?
No, we're good.
You know, we don't get questions in two ways. Either I'm doing a really good job or I'm not, one or the other.
No,
We'll
they're
bank
picking up
on-
what you're putting down.
We'll bank on you're doing a good job.
I like that. Yeah, thank you for coming in on a Sunday again, everybody. I really appreciate that. It's you know, it's a good time, Sunday evening. So thank you for coming in.
All right, polls are slowing down. Let's put the display up. And we have 16% saying yes routinely, 24% saying sometimes, 42 is your winner at rarely, and 18% going never.
Okay. Well, I hope I change your mind after we discuss this case that's coming up. When I was a resident at ICO, so Illinois College of Optometry, I did my residency there in pediatrics, and I was trained by a pediatric ophthalmologist. He had just joined ICO, or University of Chicago, actually, and we would go there as our adjunct from ICO to see pediatric patients. He trained ophthalmology residents and us pediatric residents at the same time. And he said to us, see your patient, turn around and see the sibling. At that point, as a new resident, barely 1 week into residency, I was like, you got to be out of your mind. Because it took me an hour to see a pediatric patient, like my patient. What makes you think I'm going to turn around and see their siblings? And some came in with 2 siblings, 3 siblings, and I'm like, yeah, not happening. Well, fast forward that to the end of residency, and we all got trained to turn around and look at our siblings. Fast forward that to 20 plus years of practice, and I still do that. Over the years, I picked on retinoblastoma, I picked on anisometropia, and few things here and there. It's not all the time that there's a problem, but it is a very good way to build rapport with your patient. It increases a trust with your patients. And you know what? If you find something along the way, you've just helped these patients. So in my world, I will do it. And I hope you think about incorporating that in your practice as well. And those of you who are already doing it, kudos. All right, let's move on. So this is a 4-year-old who is a sibling, because we just talked about it, who's a sibling of the patient that I actually see. So came in for an ambly follow-up. I'm looking at the patient's brother, and I'm ready to dilate the patient. So as I walk out, I see this kid in the stroller, and I said to mom, hey, mom, what happened to his eye over there? That being a mommy myself. And mom says, he got hurt. She was like telling me, like, I said, hurt? How? Like, that's a pretty bad bruise over there going on. You know what? I don't know. How don't you know about this? Because that bruise, something had to happen. Unless systemically the kid has easy bruising, right? You're thinking of systemic stuff also. Anyways, I kind of listened to this. I had the patient's sibling dilated, and this kid is playing in the waiting room as I'm walking around seeing other patients. Gut was not feeling good. And in my world, if my gut is telling me something, gotta do it because it's a mommy gut. It's forget the clinician side of it. It's a mommy gut. So the kid is 4-year-old, discoloration around this left lower lid. Mom thinks there's trauma, maybe. No idea. Mom didn't see it. Kid didn't scream, yell, nothing. It's been going on for 2 weeks now, and you can see that bruising in the later stages, right? So I'll show that picture to you. You can see that bruising where it's on that later stages of the bruising. So my gut wasn't feeling good. So I said to mom, listen, mom, can I see the kid here? You're here, I'm here, let's do this. So she was with it. She said, sure, no problem. So we added him to the schedule. Fixates and follows, will not read anything. The kid was pooped out. We had waited too long with the sibling, and I took too long to say, let's see you. So I only got a fixate and follow, which happens on many days of clinic in my world. EMs are full, ortho for distance and years, so no strab. Maybe a proptosis on that left eye. I don't know. I was looking through the lines. I was like, I don't know it's there or not. But okay, I'll keep that in my mind. IOP is normal. Front and back of the eye looks great. I felt like wanting to tell mom everything looks good, but didn't feel like it in my way. Again, coming back to what we had said earlier, you have to think about child abuse in children. I know this family for a while, so it was not on my radar initially, but I also felt like I could not disconnect from the thought that there was no sequence of thought process here. Kid had got hurt, bruising there. That's not a typical place to bruise unless you know ball came and hit me. I bumped into the island because 4-year-olds could be a little bit around that height, maybe if you're a tall 4-year-old. Maybe an end table, like you would know. So I'm thinking, mom said denied any kind of bruising otherwise. He's a 4-year-old boy running around. So if he's had some systemic bleeding excessively, it would have shown up before too. So that was nothing new. So I called his pediatrician and I said, gave her the idea of what's going on. And I said to her, don't feel good about this kid. I don't know. What do you think about child abuse? And she said to me, I've known this family. I see 3 of their children, and I don't think I have any issues about that. So Now the question was, do I just want to report it because I felt so, or should I be thinking a little bit more? So we both went with our gut and she said, send him over to me. Let me look at him. And then if I have to, we'll call child services. Okay. In this case, you have to think about neuroblastoma, and we'll talk about it as we go along. All right. So they saw the pediatrician. The pediatrician went over other questions, and remember, you have to ask them if you're waiting for them to give you an answer. 9 out of 10 times, it's not happening. So you specifically have to break it down and ask the parents too. Is your kiddo having any issues, belly issues, head issues, systemically? And mom said, he's been having some diarrhea for the past few weeks. Okay. May or may not be associated, but good to know. But the pediatrician thought she found a non-tender mass that was palpable on that left upper quadrant of the abdomen. So no neurological foci deficits right away, but she went to get more testing done. They get the CBC done, and he has mild thrombocytopenia, which is platelet count is lower than normal. Kind of makes sense with why he had the bruising. But again, don't rely on one number or one thing. You have to rely on the picture, the whole puzzle, right? You're not doing one piece at a time. They did the urinary catecholamines and saw elevated VMA. Now, these are hormones like epinephrine or norepinephrine, which gets metabolized into the VMA. So if the VMA is elevated, you can see that in some kind of tumors that secrete these kind of adrenaline hormones. So it is like one of those things that can be associated with the tumor. So again, my thought process of why I wanted to get that testing done. Some kinds of foods, some kinds of medications also can trigger these things. So again, we're not basing our thought process on one number. That's like our take-home message, right? You're thinking of it overall. There are some of these cases that you'll never see. There are some of these cases that you may end up seeing. And I just want you to get take-home messages to look outside the box. Okay. Ultrasound was done of the abdomen. There was this large heterogeneous left adrenal mass. MRI was done because I thought there was that proptosis, remember, coming back to our eye. And there was that orbital metastases that's commonly seen with this kind of a neuroblastoma. And that's kind of I was seeing. It was very early on, hence the reason why it was not like a full-blown proptosis. Biopsy of that adrenal mass was done, and it came out to be consistent with neuroblastoma. Fast forwarding this, the kid has been getting chemotherapy. He's doing much better. But again, the eye has been okay, thankfully, and nothing going on there. In a case of periorbital ecchymosis in children without trauma, make sure you think of metastatic neuroblastoma. Rule out the bad stuff. And then if it's nothing, at least you thought of the worst case scenario. Why does this ecchymosis happen? The periorbital area has fragile, very thin blood vessels. So if anything kind of tumor infiltrates through it or pushes on it, they can burst, and that causes the bleeding. Treatment, like I said, could be a combination of chemo, surgery, radiation, immunotherapy, or one or the other. And in this case, he did end up getting chemo. So take home message from this. Please look outside the box. Think of all the things that can happen. In a normal case scenario, you would see what we call raccoon eyes. You didn't see it in my patient. That's kind of why that neuroblastoma didn't prompt right away. That's why I was thinking, is this even a neuroblastoma? Should I have this kid go through all this workup? But in a normal case scenario, if you saw any of these raccoon eyes, that's your trigger. Yes, they are almost always associated with neuroblastoma. I think given fast forward, if we had seen the kid in a few more weeks, maybe the other eye could have it too. Maybe other places would show the bleeding, and hence the reason. So I hope this triggers you to turn around and see your patient. Takes only 2 seconds. I'm always behind, so another 2 seconds is not going to make a difference in my world. But it can help your patient, and I think that's the thought process, right? When you're doing pediatrics, even geriatrics or any other patients, when we're in this profession, we are helping them, and that's more important. All right. 4-year-old comes in, rule out amblyopia, failed his eye exam at his peds, and that was referred to see me. I love it when parents don't think nothing is wrong with their kid, even though they fail to think. I get that all the time. And many of the times, yes, there's nothing going on. And the testing at the pediatricians was a false positive. And then when sometimes there is a problem, and thankfully they picked on it. His left eye has been wandering for the past 3 months where they've noticed it, but they didn't think much of it, thinking, these kind of wandering eyes fix themselves. So they felt like it wasn't a big deal to see an eye doctor. He's on no medication, health is good, vision's 20/25 in that eye, and in the left eye was 1/400 with an eccentric fixation. And I wish I had videotaped him doing this testing because I almost always do the right eye first and then do the left eye. And I finished the right eye kid so wonderfully. When I went to the left eye and did his vision, the kid really couldn't see much. So we were hand holding to get him to the screen. And I remember mom saying, he's just kidding. He's just playing around now. And I was like, I have yet to come across kids who are malingering only in one eye. I see a lot of malingerers. My own child malingered as well when she was 8 years old. She wanted glasses. She malingered her way into the office just to wear plain old glasses and do fine. We went to Claire's and bought a plain glasses to make her happy. So I've gone through that, but I've yet to see a kid malinger in one eye. So makes no sense. He had no RAPD. Again, in that age group, sometimes it's difficult to see it, so we can argue if there was one or not. IOP was okay. He had left exotropia for distance and near, very poor control. Anterior segment was normal, so let's look how the posterior segment looks. Lot of exudative stuff going on in the back. There was an area of retinal detachment as well, and everything going on in this macular area and in the mid-periphery. So looking at just the picture, I was suspicious of Coates disease, but we almost always want to rule out retinoblastoma because sometimes these exudations, the way they look elevated with the retinal detachment, and they can kind of mimic a retinoblastoma as well. So you should always keep that in the back of your mind. Now, I'm very blessed I worked at Wills. Dr. Shields is just literally a couple of floors across. So I can go up to her and say, I have this kid. Would you mind seeing this kid for me? And we go from there. So she did agree with me. There was a lot of exudative retinopathy for 80% of the retina. She did say it was Coates disease. It is telangiectasics for on the FA. They did cryotherapy times 3 sessions to help with stopping those bleeding of those vessels. Vision in that right eye, of course, remained 20/20 because there was nothing else going on in that eye. The left eye was counting fingers at 2 feet, pretty much what I got earlier. Vision did not improve. We did a little trial of saying, should we patch? We tried. When you have such poor vision, they really have a hard time seeing through it. So unfortunately, patching is not going to do anything. So we decided to hold off. This sensory left XT is going to be there. And as long as it doesn't affect the patient socially or the parents feel like cosmetically it's a problem, there's no reason to fix it. But if they ever decided they wanted to fix it for cosmetic social reasons, our pediatric ophthalmologists are absolutely wonderful to do a strabismus surgery to fix it. Now, when we're talking about sensory strabismus, make sure that you always tell the patient they think surgery will fix anything. So they feel like you'll do the surgery, the vision will come back and we'll be good to go. No, no, no. The vision's not there because the retina looks awful. So they need to remember that the strabismus surgery is only going to fix how the eye looks socially and cosmetically. Because there is poor vision in that eye, this eye will drift out again at some point. So 85% it'll stay straight, but that 15-20% is going to drift out eventually. And many of these kids eventually need another procedure to kind of bring that eye back in. Glasses are crucial. Plano glasses, the kid need nothing for the right eye. So Plano glasses for protection, sports, full-time wear, because guess what? They have one good eye. God forbid something happens to that good eye. That's a problem. So we want to keep that in mind. I hate saying that word, so I'm going to skip that. It's a neurovascular disease of the retina. I never get it right. There's development of abnormal vessels in the retina. You get leaky blood vessels and you get more fluid buildup in the retina that can cause retinal detachment. A real etiology is not known, but we know something triggers in that neurovascular retina, in the neurovascular part of the retina that helps with this leaky blood vessels. Mostly unilateral, as in my patient, mostly males, as in my patient, but females, when it affects them, it's usually bilateral. So there are some studies that were done, and I just picked these studies that show that there was a case of bilateral Coats disease in a 5-year-old girl, which was bilateral. So just because we're trained sometimes to think that Coats disease can only be unilateral, remember that they might be asymmetric findings. Maybe one eye is a little less than the other, but there's definitely a possibility of having bilateral Coats disease, especially if it's a girl, which is many of the research has shown us. Also, if they present at a younger age, like my patient, it is associated with more advanced stage and a very poor visual prognosis as seen in this kid. Even though this kid ended up with getting treatment done, it really didn't do much for his vision. It'll stop it from being worse, but his vision was already very poor in that eye. If untreated, which I think this was brewing in for a while since the patient has been seeing that eye wander, but they were kind of just not very hesitant to bring the kid in. It can lead to retinal detachment, glaucoma eventually, and a combo of other things that come with it. Laser therapy, cryo injections, VEGF injections, or surgery are sometimes things that the ophthalmologist, retina doctors do. In our case, they ended up helping out with the retinal detachment. They did a surgery, but at the same time did the cryo for all that exudative retinopathy that was going on. So that's Coats disease. Okay. All right. If I haven't bored you yet, let's keep moving on. 10-year-old. Let me give you a little background of this 10-year-old kid. So I see the sibling for a regular routine eye exam. But the family went to the to one of the Carolinas, I don't remember. This kid was on a bike, fell down, and got hurt right near his frontal area. Right here is what mom tells me. They came back from, they went to urgent care while they were there, got an x-ray done like they should, showed no fractures. They said the bruising would get better over a few weeks, and it did. They came back after vacation. They saw their pediatrician. Pediatrician said, since it was right around the orbit, why don't you go and see your eye doctor? Just make sure everything looks okay. So this was really like, come, let me check you, make sure you're okay. Urgent care, no fractures, like I said. Come back and see me. The kid comes back home, gets sick, then sees me 6 weeks after that initial trauma happened. The kid is not complaining of anything. So we're literally here to make sure there's nothing going on. Vision uncorrected is 20/20 in each eye. Pupils are normal. Confrontation visual fields are normal. IOP is great. Anterior posterior segment is great. And I'm very happy to tell the parents everything looks wonderful, because that doesn't happen in my world, because I see kids whose IOP gets worse, and then I'm like, oh, now you have glaucoma. Okay, glaucoma is uncontrolled, because I co-manage a lot of glaucoma patients with our pediatric ophthalmologist. Then I have times when they're not patching, and I'm like, come on, you can patch, but then they don't do patching. So we have those bad days and good days. Then I have days when they have something structural happening in the eye that I cannot fix. So when I have a good day like this, I'm like, this is awesome. But this is getting back to why we're presenting it. If it was a normal case, I wouldn't be presenting it, right? So let's look what's going on. So this kid is sitting in the chair and having this unilateral rhinorrhea going on. Just a little bit of trickle from his one nostril. And I'm just looking at him. He's constantly rubbing his nose, and I'm like, what's happened, kiddo? Just because I want to know, nosy, and I want to know what's happening. He says, I had COVID when I came back from my vacation. I went to the pediatrician, and he said that this is kind of the aftermath of the COVID and it will go away. I asked the kid more questions. Any headaches you have? Anything else going on? And it just doesn't make any sense, right? You're having rhinorrhea from one side of your nostril. You have no history of allergies because people can have rhinorrhea because of allergies, right? You're kind of having, but then it's both nostrils, maybe, and or a runny nose. So I'm suspicious it's on the same side of the where you got injured. Kind of, again, looking outside the box. So I called the pediatrician. And the pediatrician and I are arguing now. I don't like to argue, but I was at a point, the pediatrician was like, nope, can't happen. The x-ray showed nothing was going on. Kids not complaining of headaches. So I was like, I'm not going to fight with you. You refer patients to me. I'm going to call it today and just walk away. I did tell my idea to the parents. I said, your pediatrician's not on board. But I don't know. Something about this scenario doesn't feel right. And that's my own personal opinion about it. Mom's known me many years. She said, Dr. Rana, if it turns out to be nothing, at least we looked at it. Okay, I'll just go to the ER. And sure, she went. So when they went to the ER looked at it and did say it was a CSF leak, and they did a blood patch as treatment. So let's talk about what they do. What is a CSF leak? First, where is your CSF fluid? The CSF fluid sits between your brain and your dura. It's kind of in between there, kind of circulating in there to kind of just protect that brain. Now, CSF leak means it's that abnormal escape of that CSF from some reason. Somewhere there's a tiny hole that the leakage is happening. It's clear fluid, it surrounds and cushions your brain and spinal cord, and it maintains the intracranial pressure of the brain. That's kind of its job. Now, the causes why you can have a leak could be a head injury or a skull fracture, like a motor vehicle accident, the surgery of the brain, spine, or sinuses, because then they're all in that area. Or you could have spontaneous leaks, and this was more when I was researching that with some connective tissue disorders and with an increased ICP, you can have spontaneous leaks. I've not seen it per se, but I just happened to research and come across that. What are your common sites of CSF leak? A skull base where you can leak, spinal leak is common. What are your symptoms? This clear drainage either from your nose or your ear, because that's closest to the brain where they can kind of come out of. It is worse when you're leaning forward, right? So why is that? Because the venous pressure in the head increases when you lean forward, and it pushes that CSF to go to a weak spot because of gravity. And wherever that leak is, that's where the CSF is going to go. And that's why when you bend forward, you're going to have more of that clear fluid draining. So that's one way to know that this is clear, a CSF leak. The kid should complain also, or the adult should complain of a postural headache. In our kiddo, he didn't really complain of headaches. I don't know if he just had a higher tolerance, if he just didn't understand he had a headache. I mean, he's 10, he's smart, but again, he did not complain of a headache. Postural headache is worse when they're standing up. So this is the theory behind it. When you stand up upright or sit upright, your brain will sag when there's a CSF leak. And when your brain sags because of gravity, it pushes on the pain sensitive structures like your meninges, the blood vessels, the cranial nerves, and that stretching of those structures causes the postural headache. When you lay them down, that headache in few minutes disappears. Another way of predicting it's a CSF leak. Nausea, neck stiffness comes with it, ringing in the ear. So if someone comes in with a very acute onset tinnitus and they're not on any medications and they're having some kind of rhinorrhea going on from ear or nose or wherever, think of CSF leak as well. Risk of meningitis is there because there's a hole somewhere from where the bacteria can go in and cause a risk for meningitis. So that's the big risk we take with all this. A quick chat GPT is amazing. I just put together a table, didn't have to type it myself. I was very excited about this slide. So I have a migraine, headache, and CSF leak because, listen, a lot of times kids and adults are having migraines as headache. Not everything is a CSF leak. So what am I picking out of here? The headache pattern is more positional. worse when they're sitting up, improving when they're lying down. And they usually do that in ER because they are not going to do an MRI on someone that they don't think is a CSF leak, right? Migraine, no positional, usually sleep it off or just relax, and that helps. Headache quality is more like pressure in the eye or the area in your head, whereas migraines are more those throbbing and pulsating pain. Headache location is more for this in the back of the neck and can be diffuse, whereas migraines come in with one-sided or can switch sides. Triggers mostly for CSF leak would be like a spinal tap they've had, injury, epidural surgery, spontaneous leaks, like we said. Your migraine can be triggered from hormones, stress, sleep changes. Clear fluid with the CSF leak, you're not going to get any fluid with a migraine. What else can we pick on here that's important? With a CSF leak, you may not get nausea and vomiting, but with a migraine, they almost kind of come with that, right? They're common with it. Neck stiffness, more common with the CSF leak, may not be with the migraine. And then lying down again, more improvement with the CSF leak and not with the migraine. Imaging findings, when they do MRI, you will actually see that brain sag in a CSF leak, and in a migraine, it usually would be a normal MRI. So how do they do the testing? So this is what I learned when my kid went to the ER. Instead of doing the MRI before, they just said they did the postural stuff. The kid had no headache, so he could not really say that my headache was better because he didn't have headache. But they had him lean over, and you could see that rhinorrhea getting worse. But they also did a fluid test for beta-2 transferring, which is a protein very unique to CSF in the ER. So that way they tested that that was indeed a CSF leak. And then they did an MRI and they found that little spot where it was a hairline fracture from where the CSF was leaking. Conservative ways for treatment would be just resting, hydration, and we call it a day. But in many times they do blood patch to help with it. So they actually take the patient's own blood and they kind of inject it slowly into the epidural place where that leak is or near the leak, and that should clot and seal the hole. And that usually is a great improvement in these people who have headaches, maybe in 2-3 hours after this is done. Or surgery if there's a bigger leak going on or a bigger hole that they have to fix, then they do surgery. It's an interesting case, right? So always look outside the box. All right, I'm ready for poll 3, but now I remember to read the question. So when you notice leukocoria, which is white pupil in a child, what would be your first condition you should think about? Topmost condition that I want you to think about. A, retinoblastoma, B, a congenital cataract, C, retinopathy of prematurity, or D, Coates disease.
You're good on the questions, Nidhi, but somebody did make a congratulations on the neuroblastoma case. She said great detective work. And I have a question about the CSF leak. How did the pediatrician respond to all this information after the fact?
She didn't call back, so I'm thinking she kind of thought to herself, well, the kid's taken care of. I mean, no, I didn't talk to her, so I have no idea. But I mean, in the end, the kid's taken care of, so that's all that matters. Can't ruffle the feathers. She's still a referring pediatrician, so I'm going to keep it at that.
Okay, polling questions open. Looks like everything's rolling in here nicely. I'll display the answer. We've got 76% going with retinoblastoma, 18%
Right.
going with congenital cataract, 2% retinopathy prematurity, 4% Coates.
All right. Well, the majority of you got the right answer, which is exactly what we want to learn out of this. So this is a 2-year-old male who came in because mom noticed a white in the eye. She said, my kid has a white in the eye. Our staff knows how to triage these patients, put them on our schedule. And I happened to see this kid. Mom has just noticed this for the past couple of weeks. No pain in the eye. Kid is not bothered by it. No other symptoms. Kid's never seen an eye doctor prior to this. No medications that the kid's on. Birth history is otherwise unremarkable for this little one. So I took a picture of the eye, and you can see, because I want to show mom what I see. You can see that little white in the eye. It looks not as superficial that it's outside on your sclera, but it looks like a little more deeper in the eye. So that is what mom was seeing. Fixates and follows well in that right eye, which is not the problematic eye. But as soon as I cover that eye, we are screaming bloody murder because I am covering an eye that he probably can't see with. Question of an APD, again, always with a grain of salt, 2-year-old screaming already. They say terrible twos for a reason. Even though I like that age, they do say terrible twos for a reason. IOP was okay, anterior segment was okay. I do everything that we can when we have them dilated. So cycloplegic retinoscopy on that one eye looked great. That's age appropriate. Left eye was so dull, I couldn't even get a reflex. So again, this is all triggering, boiling down to something going on in the eye. You look in the back of the eye and you see this big, humongous mass sitting right in front of your eye and you're like, oh, okay. So already what I was thinking and what majority of you were thinking is I want to rule out retinoblastoma. Looked exactly like it, but again, wouldn't be sure unless we did more testing. So I still have to think of other things, but retinoblastoma on that list of Coates disease, retinal detachment that can come with it, retinoblastoma. Retinoblastoma is definitely the worst case scenario. So always remember you're ruling out worst case scenario even in your adults, but I'm going to say pediatrics because that's all I see. So we did an ultrasound, the B scan, and if you look in the ultrasound right here, you can see these calcifications. That's kind of pretty pathognomic of seeing retinoblastoma stuff with it. So this kind of also triggered that it's possibly that. Called the shields again. Thankfully, they're only a few, doors away, so I was able to have the kiddos see them. She definitely thought it was retinoblastoma as well. And she found it in both eyes. I did not see it in the other eye because it was more peripheral, I think, and the kid was already screaming. What I could see is what I saw. But she did say it was in both eyes, and they had to end up enucleating an eye. So, unfortunately, couldn't save one eye. But that's okay because he has a one very good eye. The other retinoblastoma, little pockets that he had on the other eye, they were able to cryo it and laser it. So, he's doing really well at this point. When the surgery is done on that eye and they nucleate the eye, they put a conformer in the eye. It's almost like a little plastic contact lens, so-called, which is not very soft like our contact lenses. It's a conformer to put on the eye so the eye does not lose the shape once you've enucleated the eye. If the conformer falls out, it's like putting back a contact lens in. Mom came in a few times because she didn't want to touch the eye, which is rightfully understandable. So we just put it back in, and eventually they do end up getting a prosthetic. Look at that. That prosthesis is amazingly done. It was done at CHOP, and it looks beautiful. We can tell which is what, but to a regular human eye, to a regular lay person, it probably looks amazing. So he's doing very well since that. Because he could not know the difference. He was seeing with one good eye. He still sees with one good eye. So when he had the surgery, he was a little cranky that when he looked in the mirror, one eye was looking different. But once he got the prosthetic, believe me, kids are resilient, and the boy is doing really well. Retinoblastoma is an uncommon childhood cancer of the eye in a big picture. I work in a scenario that I see it commonly, so unfortunately, it is common in that scenario. It affects the retinoblast, the chromosome 13q, or the RB1 gene. It is usually diagnosed on the age of 2, even up to the age of 5, and has been documented in even as old as some teenagers. 75% of them are unilateral, more of the sporadic kind, and 25% are more the bilateral or the familial kind. Boys and girls have equal sexual predilection. The familial one, just like the name says it tends to run in families, mostly bilateral, diagnosed usually under 5. They have more risk of metastasizing to the pineal gland, the bone, and the soft tissue. So if you are seeing a sibling of one of these patients who does have retinoblastoma, make sure you're seeing the kids, or if mom had retinoblastoma or dad had retinoblastoma, you're evaluating these kids as a newborn. Then every 3 to 4 months till they're about 3 to 4 years old, you're getting them through that stage where it's a risk. Then you can see them for a couple more years, maybe every 6 months, and eventually you just follow them annually, because the risk of having the familial kind after the age of that 5 or 6 is almost negligible. So you're just concentrating on seeing them when they're younger because that risk is higher. The sporadic one has no familial history, just happens. It's mostly unilateral. It can be even diagnosed in as old as teenagers. 1 to 2% chance the siblings have it. So if I see a teenager with the sporadic retinoblastoma, I will tell the parents, let me see the kids, other siblings. I've never noticed anything else, but it is documented that there's a very small risk with it. These don't have a risk to metastasize at all, so that's the good news with them. So these are a couple of articles that I picked. One of them was the retinoblastoma in Chinese children, age 5 to 14 years, and they did notice about 10 kids that they'd seen between the ages of 7 and 14, and their upper end was the 14-year-old. Dr. Shields, back in the day in 91, she had, it is a very old article, but she did see kids even as older as 18-year-old that have this. Now, if kids complain of floaters, will you see every kid? I don't think so. But what I will say is if it's consistent, it's make sure you see them. So I'm not saying the kids who have floaters, you should not see them, but the way my office or the clinic triage them is saying, okay, we'll see you in like 2, 3 weeks or whatever. But if they're saying, oh, it's consistent, I'm really seeing these floaters for the older kids, yeah, they're seeing us either in the WILZR or they're seeing us sooner at the office or something, because we do want to make sure that it's not this sporadic kind. And you're always thinking of worst case scenario, unfortunately. I rather tell them it's just a floater and we're happy and nothing's happening. Testing usually done is an MRI of the brain and spinal column. Blood tests are done, hearing tests are done, because if they do end up doing chemo or radiation or any other kind of treatment options, you want to make sure they have all their testing done. This is normally not what I would prescribe. This is normally what Dr. Shields or an oncology team that they work with usually prescribes, because we don't need to go to that level of doing it. If there is any evidence of choroidal or optic nerve invasion, that's it. Chemotherapy is necessary for those kids. Of course, unilateral versus bilateral retinoblastoma. They will try and save an eye as much as the oncology team can. Enucleation becomes common if there is any kind of optic nerve invasion or any risk for metastases. Chemotherapy is also frontline for getting that done. They do 1 session every month for about 6 sessions. That's at least the protocol at CHOP that I work with. For the other lesions that are very small, maybe in a fellow eye, cryotherapy or laser therapy or photocoagulation work pretty well. And in my patient, he's doing very well. Those lesions have shrunk. They are small lesions and they have shrunk because of the cryotherapy. So he's doing wonderful. They're not in his vision, so he definitely sees very well. So that's the good news with that baby. Okay. So moving on, there's this 17-year-old who came in, we're just talking about floaters right here, complaining of a floater that just started acutely about 3 to 4 days ago in her left eye. She has, before that, she's never seen me before this. She's seen other eye doctors before, has always had great eye exams, wears glasses, sees well, and is otherwise having no eye problems. Her vision is blurry. She's very clear about that. She's complaining of no pain, no trauma. She was sick about a month ago with the flu. There's no flashes of light. She wears the glasses all the time. And the last time she saw her eye doctor was about a year ago elsewhere, which was unremarkable except for glasses. She's a low myope with some astigmatism, sees 20/20 in one eye, 24/50 -2 with no pinhole improvement in that left eye. Pupils were normal, color, confrontation visual fields were okay. Color vision in the right eye was okay, which I should have put that in. The left eye, she really was having a hard time seeing them. So I feel like there was some trouble in seeing that. No apparent strabismus. She was pretty ortho. IOP is good. Anterior seg is good. So this is a case of the posterior segment. So when I look at the eye, I see this white dots on her fundus. She had a decreased foveal reflex. It was really hard to even get a good foveal reflex. And because, again, I'm blessed that I work in a department where all the departments are in the building, I just called retina and I said, I'm seeing this kid with these white lesions in the on the fundus, and I was hoping that you could see her. So it was easy. They went downstairs to see retina, and retina diagnosed her with a white dot syndrome. Retina would not give me the OCT, so I did not have any OCT of this kiddo because getting them to give any kind of feedback back was not happening. But white dot syndromes are inflammatory diseases. It's a group of inflammatory diseases that affect the outer retina, the RPE, and the choroid. They are very commonly associated with viral illnesses, so hence no surprise there. This kid who had the flu about a month before she started seeing these symptoms. You can see these white, yellowish kind of lesions in the fundi. In this case, it only happens to be in her one eye. The different types of white dot syndromes are your MUDES, your birdshot chorioretinopathy. There's a whole list of other ones, but I kind of picked the ones that were more common. And your APMPP, which is your acute posterior multifocal plassoid pigment epitheliopathy. But our retina department gave me a whole list of what it could be when I walked downstairs, telling them what I saw. Like I said, I picked the ones that were the most common ones. So the treatment is usually self-limiting in 3 to 9 weeks. This kid, I had seen probably 2 months. So retina was following them, and usually after they follow them for a little while, they send them back to see us in peds. So when she came back to see me, which was about 2 months later, she almost looked like she had resolved everything. Her vision was back to 2025-ish. We were hoping that maybe at some point she would go back to 2020. They did no treatment except watching it. Now, there was an article that I was reading recently about it that said there is a risk of recurrence to up to 10%. So we did educate her. She was educated by retina, but when I read the article too, it kind of made sense to remind her that since she has the risk of it to come back when she's sick, she should be more aware of knowing that if anything happens, to come back and see us or retina, it doesn't matter. So that was white dot syndrome. Okay.
Nidhi, before you go too far,
Yeah.
a couple of things came in about the retinoblastoma. After they get the conformer, is anything they need to be looking out for with the conformer?
No, good question. No, nothing to look out for. It's literally like a little plastic piece that just goes back in like you would put in a prosthetic or you would put in a contact lens. If the kid is being irritated by it, sometimes Dr. Shields will put them on erythromycin ointment till they get to the prosthetic, just so that there's no infection. But if they are not on an ointment, you can even use artificial tears if the kid feels like they've been irritated by it, but nothing to watch out for otherwise from our standpoint. But good question.
And any hearing issues with the retinoblastoma?
The only reason why they do the hearing test is because sometimes that can affect when they do radiation and chemotherapy. So they just want to have a baseline hearing test for these patients. But I don't know if any kind of case reports that the retinoblastoma is directly linked with the hearing issue.
All right, all good.
All right. So this cutie pie, 6-year-old, comes in, smart as can be, comes in to rule out strabismus. He complains that his left eye has been turning it. He complains. Left eye has been turning in for 2 days now, and he's seeing double. So when I said to him, what kind of double are you seeing? Is it side to side, up and down? He literally said, side to side double, and I see two mommies. And his mom and I cracked up and said, she was like, it's enough having one mommy who's hovering over him to do things all day long. Now he has two mommies who are going to be like that. So we were laughing about it. But he's very verbal. He knows he's seeing double, and he does not like seeing double. He's not complaining of any trauma, no illness at all. Otherwise, just randomly happened 2 days ago. No medicines he's taking. General health is good. Otherwise, a very healthy kiddo. Individually, vision is 20/25 in each eye. Pupils were normal. Confrontation visual fields were normal. Color vision was normal. Ret was a very low myope with some hyperope with some astigmatism. So normal in his age group. So obviously no significant refractive error. IOP was good. a little mildly decreased stereo, and he does have a 25 prism diopters, left esotropia for distance and near. Anterior segment is normal and posterior segment is normal. So the eye, except the strabismus, looks perfectly good. So this is an acute onset ET with the diplopia. Kid is very verbal about it. Happened only 2 days ago in no setting of viral illness, no setting of vaccination, no setting of trauma. What do we want to do? He needs no glasses, we know that. But he's complaining of diplopia. He's very verbal about it. Dr. Rana, I am seeing two things. I am miserable and I need this fixed. So we gave him glasses with fresnel prism just to help with the diplopia. We tried to see where he would be single, and he literally needed 25 prism diopters base out in front of that. Okay, so you can choose, right, whether you want to do it in front of the right eye or the left eye. We chose to do it in front of the right eye, and I'll give you our rationale behind it. The left eye is crossing. He's 6 years old. He can have a risk for amblyopia, right? Again, trigger in our mind for pediatrics. That because that eye is crossing in, if I covered the right eye, he's going to kind of really push to use the left eye. And when he pushes him to use the left eye, we hope that he doesn't develop amblyopia because that eye is not being used. If I covered that eye with the fresnel prism, we know his right eye is already the weaker eye. The left eye will continue crossing in, and we have that risk of amblyopia. So that's kind of the rationale behind why we picked putting it in front of the right eye. So this one is slam dunk case, acute onset ET with diplopia. You are going to need to do an MRI, brain and orbits with and without contrast, period. We do that all the time for kids. There is no only brain, there is no only eyes, maybe in some cases, but you're putting them under sedation, you might as well get everything. Now, saying that is easy. Fighting with the insurance is a whole different thing, because the insurance will ask, why am I doing both? Why shouldn't be doing only with and not without, or vice versa, or whatever it is. And you kind of just have to say, you're putting them under sedation. I want to make sure that we get everything we need so we don't have to put them under. And usually after that, I have a peer-to-peer with the insurance, and they will kind of accept it and give you go from there. So that's usually the thing. This kiddo has a coincidental finding of a small pineal cyst. Anytime you get an MRI done of the brain and orbits, somewhere you're going to see that pineal cyst come up. It was very insignificant, coincidental finding. You just watch it. So this kid has no brain tumor going on, no issue for this acute onset ET with diplopia. All right. This is a 6-month follow-up, but we have continued to see him over time to make sure this is not getting worse. He's okay with that fresnel prism. He hates his glasses because he does not need them otherwise, but he also likes that he doesn't see double with it. Instead of just patching one eye, he puts his glasses on and does fine in school. Every 2 to 3 months, and I consulted with our pediatric ophthalmologist, and I said, listen, he's diplopic. We checked for any brain tumors, no brain tumor. Do you want to just operate on him and call it a day? Because what are we waiting for? And her rationale was, I'm going to wait 6 months at least from the day we started this process, because some of them can show an improvement in that time frame. Now, this is very variable. Whoever you work with, I have pediatric ophthalmologists who I work with that are like, my thought process, why am I waiting? We watched it for a couple of months. We triaged it. We said MRI is done. No problem. What am I waiting for? Let's do a strap surgery and get this kid as straight as possible. Neuro-ophthalmology at CHOP tells us wait 6 months. So we're actually doing a study on this. I don't have the results on this because we're still working on it, but there would be probably an article or a research paper that comes out of this. Hopefully I'll give you better results of why we do this and what should be the care of thought once we have that results. But that's an ongoing project that we're doing at Wills. Okay, no changes in his esotropia or diplopia at 6-month visit. Diplopia is relieved by his fresnel prism, like I said. There's nothing to wait for. You do the strap surgery. She did medial rectus recessions, no diplopia at that time, no ET after that, and no glasses needed because now you fix the problem. This was an immediate picture that was done on post-op, I think week 1. So he has some redness in his eyes from that strap surgery, but look at those reflexes. There's so straight. I've seen him multiple times after that procedure. This kiddo is still looking amazingly well, still straight on and everything. That little bruising on his eye, come on, he's a 6-year-old kid running around, just fell, got hurt, documented got hurt. So that's why nothing to worry about that. But in the picture, you can see it. So I just wanted to clarify that. All right, so that was my cutie pie. Very sweet kid. All right, Greg, I'm ready for the poll 4, but let me ask the question. Which systemic disease is most commonly associated with subluxated lenses in children? Your options are Marfan syndrome, A, Down syndrome, B, C, neurofibromatosis, or D, Turner syndrome.
The answers are rolling in.
Joe, any other questions that came up? No.
Nope,
All right.
you're good.
Checking along here. I enjoy speaking, guys. So like I said, when you do the survey, please, if there's anything I can do to make it more, make it better over time, I am very happy to get those feedback. So I appreciate you again being here on a Friday, I'm saying on a Sunday evening.
All right, let's display the answer. We got 94% saying Marfan syndrome, 6% Down syndrome, and the rest are 0.
Great. So Marfan's is the right answer, and we'll talk about that in our next patient here. So this 1-year-old came in because mom wants to rule out myopia. Mom is very nearsighted, like a 10, 11 diopter myope. She sees her daughter sitting close to things, and she says to me, I am pretty sure this kid is nearsighted, but I just obviously want to get a full eye exam. So she brings her in at age 1. No medicines that the kid takes, healthy otherwise, no medical issues, fixates, follows, does what she needs to at a 1-year-old, pupils are good, EUM is okay, ortho for distance and near, very dry, I'm saying, very dull reflex when I'm just scoping her. So normally when you see little kids, just take your retinoscope and kind of do a dry ret. You don't have to do a full retinoscopy at that age group because they're focusing so much. They're going to vary in occasion and you're going to get this reflex that is all wrong. So it's just good to get like a glimpse of what's going on. And I like that because when I see them after dilation, when they're cranky, at least in my head, I know what ballpark I am in. So very dull reflex. So I'm like, she definitely looks like a myope. So, when you see dull reflex, this is the normal tendency to pick like either a 10 diopter plus or a 10 diopter minus and see kind of where I am. And because mom is a high myope, my first gut feeling was, let me just take I don't know, I just picked an 8 diopter loose lens, put it right in front of her eyes, and I was scoping her and I was getting somewhere close to that. I said, she's definitely a myope. Now, when I see that, can I dilate her in the office or in the clinic? Yeah, I can dilate her. But sometimes to get a better look and a good dilation, I will actually pre-dilate them. So I sent mom home with atropine eye drops, 1%. I usually do a night before the appointment, 1 set of drops and 1 set of drops in the morning of the appointment to see me. So we're pre-dilating. We want to make sure that they have a good, nice pupil dilation. My cyclopentolate sometimes won't give me that, but these kind of does the trick. Atropine will last longer, unfortunately, but we get what we want, and I wanted a good dilation with it. So that's kind of why I pre-dilated. So never feel like you can not break up your office visits in some way as long as you can rationalize it for the patient. When she came back for the pre-dilated exam, look at how much of SIL and how much of astigmatism we have. I mean, how much of nearsightedness and astigmatism we have. Just like mom said, high myope. But as I was doing the reflexes, I was like, something about that eye did not look right. So I took up my handheld slit lamp and looked at her eyes with it. And she had these subluxated lenses nicely moved out of place. And I was like, oh boy, no wonder I was not able to see as clear as I would want to. I still was able to refract her from the phakic part of the eye, so from where the lenses are. But you could obviously see that the reflexes were not great as you would see otherwise, and hence now we figure out why she had that. Okay. In bilateral cases, we almost always want to think systemic disease. You said that Marfan's is the most common one, and yes, that's what I'm going to think about. In unilateral cases where you have a subluxated lens, always think part of trauma because that can happen with trauma. Refraction can be done either from the phakic part of the eye where the lens actually is, even if it's a little subluxated, or you can refract them from aphakic part. If the lens is more out of place, you're still able to get refraction from the aphakic part. Sometimes our surgeons are not very keen about doing the procedure because the lens is out of place, but it's not out of place for them surgically, so they don't end up doing the procedure. That's where sometimes I'm refracting them through the aphakic part and giving them glasses and their prescription. So again, just a picture over there. So the most common connective tissue disorders that are associated with subluxated lenses, just like you very correctly pointed out, Marfan syndrome, you have homocystiuria, Weil-Marchesani syndrome, and in the end of the day, isolated ectopia lentis, which means there is nothing else going on, and this condition is only isolated to the eye where you have subluxated lenses. That is a diagnosis of exclusion unless proven otherwise. So make sure you're doing all the other testing before you do that. Okay. So Marfan syndrome is the most common systemic disease to be associated with the subluxated lenses. Fairly common but not common. It's inherited as an autosomal dominant disorder. Both sexes are equally affected, but in this case, you don't see any developmental delays associated with it. The organs that are affected, of course, we're talking about the eyes. So our eyes are affected, skeletal system is affected, and cardiovascular system is affected. So these kids, when you are getting their workup done, they should be seeing genetics. They should be seeing cardiology if necessary. And of course, their pediatrician should be involved as well. In Marfan syndrome, let's say, when you look at the zonules, this 1-year-old ain't going to let you sit and watch and look at the slit lamp as well. You'll be happy if you get some glimpses here and there that you got some testing on her. But if you're able to see an older kid who has subluxated lenses, you can actually look at the zonules. And if the zonules look like they're stretched but not broken, like in that picture, that's usually a sign of Marfan syndrome. Marfan syndrome zonules are not broken. This isn't kids who already have diagnosed Marfan's. This doesn't tell you anything otherwise. And because I get very excited about genetics and see these patients, I make them do the thumb sign. Not that I'm diagnosing it, but I just enjoy it. You look at their palate. They have a very, very deep palate in Marfan syndrome. Some of them will have the pectus excavatum or the pectus carinatum. In the eyes, except the dilation, the subluxation, you also have high myopia and retinal detachment risks associated with it. So when you do see these kids for follow-ups, make sure you're doing your regular dilated exams to check for retinal detachment. And of course, you're treating amblyopia by giving them the prescription for their glasses. This is a very close-up picture just because I thought it was very cool. You can see the zonules over there. Your next one would be homocystiuria. It is a disease of the methionine metabolism that is caused by the deficiency of that enzyme, beta-cystathionine synthase. Patients usually have elevated blood levels of homocysteine. You can do urine test to look for sodium nitroprusside for homocysteine. It is less common than Marfan syndrome, and it is associated, about 50% of them with homocystiuria are associated with developmental delays. The organs are the same. That's why you can't pick and choose unless they get genetic testing done. The eyes are affected. In this case, the zonules are more broken. So when you're looking at their eye, if they allow you to, you can see the zonules, some of them look like they're broken. They still have high myopia and astigmatism associated with it. They have retinal detachment risks. So periodically you're checking their retinae to make sure that they're okay. And you're educating them for the high myopia risk and retinal detachment. You're going to have risk for retinal detachment if you see flashes of light, floaters in your vision, so on and so forth. Come to see us right away. The homocystiuria kids will have cardiovascular issues where they have risk for anesthesia. They can have a thromboembolic event. So that's why knowing this is very important. These Veal Marchesani kids are opposite to the Marfan's kids who are taller and thinner and longer. These Veal Marchesani kids are very cute. They're very chubby and small and so-called round. They're rare autosomal recessive and autosomal dominant disorder. The only reason I see them is because I co-manage genetic clinic also at the hospital. So I do tend to see some of these genetic conditions. Skeletally, they're, like I said, they're built small, so they usually have brachiodactyly, brachiocephaly with them. For the eyes, they will have lenticular myopia. Their lenses are almost always dislocated. They have small round lens, the microspherophakia, because they're all like chubby small kids. So the lens is small, it doesn't stay in place, and it dislocates. Because it dislocates, it can cause shallow anterior chambers that can lead to pupillary glaucoma. It can lead to angle closure glaucoma. So these lenses almost always have to be removed surgically. Isolated ectopia lentis is sporadic subluxated lenses that just happen. They're isolated only to the eye. You have to rule out everything, like I said, because it is a diagnosis of exclusion. I will share a small story with this particular patient. I was being who I am. I called the pediatrician, told them about it. We said, let them do genetic testing. We have a genetic department in Wills. Mom's closer to CHOP, so mom went to the Children's Hospital of Philadelphia genetic department to get this testing done. I got a letter from the genetist that said this is isolated ectopia lentis. And in the letter, as I read, she said, I would like them to follow only with a pediatric ophthalmologist and not with an optometrist. If there was any orifice that was left to where I could fume, I was fuming, because it was not about sharing care with anybody. In the end of the day, these kids, their care is very important. I have absolutely no problem. I work with our pediatric ophthalmologists all the time, and I'm more than happy to share care with them. But for her to say, don't see an optometrist, just triggered it. So I sat on it for a few days, but then I called her because I just could not take it anymore. And I said, I wanted to ask her, why did she think that I was not qualified to see this kid? I was the one who diagnosed this kid. I was the one who saw this kid. And she said we were not skilled enough to see the kid. And so we had a chat. I, tried to explain to her that if you're trained in that area, if you're doing it routinely as seeing your patients, you do know how to co-manage these children. And I hope I put the point across, but that was many days of sitting and fuming on it. Okay. Once the surgeon decides to remove these lenses, they many times leave the kid either pseudophakic with a secondary IOL in there, or aphakic with no lens in there. And then if you're co-managing these patients, of course, you're going to work on treating them for the aphakic part of when they're left. So lenses are removed because of different reasons: subluxated lenses, persistent fetal vasculature, congenital cataracts, trauma. You remove the lens, you leave the patient aphakic, you fit them either with glasses or contact lenses. And that's a whole different lecture talking about surgical, aphakic management or specialty lenses, but I'm going to touch on a little bit since we're talking about this topic. Glasses considerations: if it's unilateral, think of it. One eye has a plus 20, plus 30 diopter of power in there. The other eye is plano in many kids. That's a very hard difference for the kids to manage, especially if the kids are really little. Now, my youngest kid who gets contact lenses is almost only 4 weeks old. So trying to do aphakic management of doing glasses in a 4-week, 5-week, 6-week-old baby with glasses is just not possible. So contact lens it is, unilaterally or bilaterally. Age of the kid does make a difference of when they do surgery. If it's surgery they want to do for congenital cataracts, they mostly tend to do it younger. So they're able to help with the amblyopia component by removing the cataracts. Remember, thickness of the glasses, we touched on it, is so hard that's why we do contact lenses in these patients. Contact lens comes with its own thing. I do tons of these contact lenses every year, and I can tell you that contact lenses is not a piece of cake. It takes a lot of my time, my text time, my patient's time, giving my phone number, triaging it on different times to help these patients with the contact lenses as well. They become expensive. You can do soft lenses, you can do RGP lenses, and you also have to walk them through contact lens hygiene and maintenance. Remember, these aphakic kids or pseudophakic kids are at risk lifelong for aphakic glaucoma. So when I send these babies off to you guys who see mostly adults, you are also managing them to check for aphakic glaucoma during their lifetime. So we tend to see these kids almost every 3 to 4 months to check IOP and look at them. Okay. Moving on to
No, Nidhi, you have to remember, we set our clocks ahead an hour, so we're out of time right now.
Do we have time to do one more, or should we just stop?
We do not.
All right. Well, I tried. Thank you guys for having me here. I am so honored. Really appreciate being here. And thank you again, Joe and Greg, for having me. I truly appreciate that.
Not, not a problem. I'm going to have you unshare your slides for me.
Sure. There you go.
Uh-oh, where did mine go? That's not good. Where are they? There you are. Oh, there they are. There they are. They're just hiding. All right, everyone, you should see in the survey, you should see this little red dot right here. I'll put a big green circle around it. If you want to start that survey, you could go ahead and start that survey that we will give the feedback to Nidhi. After you fill that out, please do that. We need that for the gap closures, for CE broker, and for COPE. With that said, Joe, are there any other questions or any other comments that are in the chat box?
No, all just your virtual round of applause. Everybody loved the lecture.
Oh, thank you. I appreciate that again.
Perfect. Any closing comments, Nidhi?
No, I hope this lecture has given some insight in managing pediatric ocular disease. I hope it's given you some insight into how to take care of little kids and be more verbal and stand up for yourself. And we're smart. You are able to do this. And I hope many of you see the younger ones as you start to practice more. And if there are any questions, I'm always available to answer. So please feel free to reach out.
Well, as always, Nidhi, I think you've completed those tasks. I know that, as you said, we've known you for a decade. You've been lecturing for us many a times, and I know your feedback's always great, and the audience always learns those clinical pearls from you. So thanks.